Welcome to today's program, Current Issues in Cancer Care, brought to you by the National Coalition for Cancer Survivorship. My name is Eric, and it is my pleasure to be your moderator for today's session. For technical assistance, send an email to canceradvocacy@compartners.com or send a message in the chat box. Today's program is scheduled for 90 minutes and includes a question and answer segment. Please note that today's session is being recorded and all participant lines will be muted during the session. If you need assistance at any time during the program, please select *0 and the operator will help you. During our designated Q&A break at the end of the discussion, you may ask a question by selecting *1 on your telephone keypad or by typing your question in the chat box area located on the lower left corner of your screen. These instructions will be repeated later in the program. To interact with your presenters, you may submit a question at any time by using the chat feature located on the lower left-hand side of your screen. Your questions will not be viewable by other attendees. If you look to the left of the screen, you will notice the links area where you will find resources related to today's program. If you would like a copy of the presentation, click on Slide Presentation to open and print a copy of the slide. And now it is my pleasure to introduce today's first speaker, Shelley Fuldt-Nassau, CEO of NCCS. Shelley, welcome to the program. Please begin.
Thank you very much, and thank you all for joining us today. We're really looking forward to having this discussion today about current issues in cancer care, and we're grateful to Dr. Peter Bach for joining us to share his perspective. We have a really great turnout today for the webcast, and we appreciate your time. I know everybody is very busy this fall, so we appreciate you joining us and hope that you will find the webcast to be beneficial. So I just wanted to give you a little bit about NCCS's mission and some of our policy work. Our mission is to advocate for quality care for all people touched by cancer. And our policy priorities are really to ensure that every cancer patient has access to quality cancer care, including cancer care planning and coordination services. We believe that there are gaps and areas for improvement in the current cancer care system, and one of those gaps is in treatment decision-making, care planning, and coordination of the various facets of cancer care. So cancer care planning and coordination is one of our primary objectives, and we also look at delivery and payment reforms that will provide cancer survivors with access to cancer care planning and coordination and improve the quality of care that's delivered to cancer patients. As part of that, we advocate for the PACT Act, which is HR 2477, Planning Actively for Cancer Treatment, which would establish a new Medicare service for cancer care planning and coordination. We also address other pressing cancer policy issues related to the Affordable Care Act, drug and device approvals at the FDA, and other issues that impact cancer patients' access to quality care. This webinar is a part of a new program that we have at NCCS called the Cancer Policy Advocate Training. We'll have this webinar and another webinar in December, and then an in-person training in Washington, D.C., November 13th and 14th. At our in-person training, we'll be talking about FDA regulation of new cancer treatments and diagnostics, public and private payer reform and of cancer care reimbursement, and then cancer care quality measurement. And Dr. Bach's presentation today on current issues in cancer care is a really great segue into our training that we'll be having in November, and he will be talking about all of these issues and giving a good preview of some of the issues we'll be discussing at the advocate training. We do have a few spots still available, not very many, but we do have a few spots available for the training, so if you're interested in attending, please contact Kelsey Napodi, our Policy and Advocacy Manager, at the email address on your screen. And also, if you are on Twitter, please join the conversation today with the hashtag CPAT14. And now I have the pleasure of introducing Dr. Peter Bach, who is the director of Memorial Sloan Kettering's Center for Health Policy and Outcomes, and has written extensively about health policy, about his own personal experience with cancer, and has written some really thought-provoking pieces both in the scientific press and in the lay press, and we thought he would be a great person to really lay out some of the important issues in cancer care right now that we as advocates really need to understand in order to most effectively advocate for patients and for access to quality care. So we're grateful for his time, and I'm going to turn it over to Dr. Bach.
Thanks, Shelley. It's really a pleasure to do this, and I appreciate the audience. It's always difficult to speak into the phone having no idea if anyone is listening, so if you do want to respond in any way, please, there's opportunities to do that, and I look forward to your questions. I'm going to cover a number of issues, if you will. This is sort of a flyover, I think, of what's pressing on the cancer policy front, and obviously happy to delve into any of them in more detail. But these are the general domains I think it's probably worth talking about. You'll see there's a tilt towards what I view to be issues that are particularly important for patients regarding access, which have to do not only nowadays with drug approval, but also the structure of an insurance and payment reform, the role that quality measurement might play in improving transparency and hopefully net quality, and then pricing and prices and what's happened to patients as a result of that, particularly around drugs. And then I'm going to talk about this ongoing shift we are seeing in site of care and what it means for patients as well as insurers and policymakers, and the language of cancer, an area of interest for me particularly. So just so you know, it is impossible even for the experts to keep up with the number of pathways that the FDA has created and continues to develop around the development and approval of various drugs. Shown on this slide are 4 unconventional approval pathways, all designed to be faster than the conventional approval pathway that have been used for various drugs I'm about to show you. I won't read every bullet point here, but it's sufficient probably for you to think about the reality. You could think about it this way. There is criticism of the FDA that it is slow, particularly with life-saving or innovative therapies. The response that is often made is, that's not true. When there are new drugs, particularly for life-threatening illnesses, particularly when there are unmet needs, the FDA has a number of more rapid ways of getting drugs onto the market, and then once they're on the market, they can be further evaluated. And these are the 4 primary unconventional pathways. Shown on this slide, in fact, are the routes for the last dozen or so, I didn't count them, drugs approved in the last year or so. The names are listed on the left-hand side, the year of approval, and then you can see essentially every single one of those drugs that was approved through an unconventional path, and you can see then the prices, which I will come back to, for a month of therapy of each of these, all very high, the cheapest being $5,000 a month for Gilatrif. That in the old days we would have thought that was an outrage, now we think it's a bargain. There's a number of areas of payment reform I want to talk about. These can be broken up into 3 general categories you will hear about. I will try and locate these in the dialogue we are having about health reform in general for you as well. And then the various, this is from an article I recently wrote laying these out, and I talk about particularly the issue about drugs and what the structure will do to drugs and drug pricing and how hard they are to implement. On the left-hand column is something called episode-based payment. I'm going to talk about that a little bit. But the essential idea behind episode-based payment, although it's morphed over time, is to shift the risk for the cost of drugs, essentially put the doctor, provider, or hospital at risk for the cost of drugs. You give them a certain amount of money, and then they have to go buy drugs from that money. And the general direction of that, if you do that, it will inspire doctors to use cheaper drugs and will inspire companies to lower their drug prices. That's the basic idea. Doing so has a high degree of difficulty for implementation, has a lot of requirements for standards of care. And then I talk about Medicare authority, which they have as a demonstration. In fact, CMMI, the demonstration component of CMS, just published a set of standards around this that I'll tell you about in a second. There's a more simple idea in payment reform. And I should say before this that the backdrop for all of this is sort of unmonitored, unregulated cancer care, which is how you would characterize most care right now, within the discretion of doctors and hospitals, entirely paid for based on cost, so that there is no sort of structure in place to either rein in cost or particularly monitor quality. So these are all sort of approaches that would be different from that. The second one being payment for pathway adherence. I'm going to talk about that. But the basic idea there is rather than having doctors have to buy and take the risk for drug prices, instead doctors contract with insurers to follow particular treatment approaches, but the insurance company still pays for the drugs. That's easier to do. The difficulty of implementation is lower. It needs care standards from the insurer, and again, it could be done only as a demonstration. And then the last approach is third-party buy and bill. This focuses primarily on drugs. This is an old idea. It comes not that old, but it comes out of the Medicare Modernization Act of 2003. The notion being get doctors and hospitals completely out of the drug business, have a third party essentially just ship the drugs to the doctors when they need them, and that third party would take care of everything. Bill the Medicare program, bill the patient, buy the drug. The doctors would be completely out of the business, which would mean they wouldn't profit from drugs, and they also wouldn't be underwater because of high drug prices, both things that are happening and I'm about to talk about. So this is very much happening, these sorts of ideas. I just mentioned pathway adherence. Here's a front page article in the Wall Street Journal from the spring pointing out that WellPoint, one of the nation's largest insurers, has stepped forward and said if you follow certain pathways, remember that was one of the reform possibilities, you will get a payment, an extra $350 per month per patient for following those pathways, which is not a huge amount of money given the revenues of an oncology practice, but it sends a very strong signal that payers are willing to get into this business of paying doctors to do certain things more often. All of this stuff is against the backdrop of a very important lesson that can be sometimes overlooked, which is that it is the case definitively that if you pay for things one way, doctors do something different from if you pay for them a different way. And that is either an opportunity or something to be terrified about, or maybe it's both. But we do know from years of research looking in a bunch of different ways, one of which is shown on this slide, that shifting the way doctors make money or lose money affects what they do. And on this slide, these three squiggly lines show something pretty alarming. If you look along the X or the horizontal axis at the point 0, you can see that the use of the blue line plummets, the yellow line goes up, the red line starts to go down. Those are the use of 3 drugs for lung cancer, and at that time 0, payment rates changed for those drugs. And the rates of use changed too. So you can only interpret one thing from this slide, which is that if you change the incentives, the profit and loss for drugs for doctors, they will prescribe drugs differently. And this is in a condition where we know what is optimal. This is in lung cancer, and this is a Medicare population. The subsequent slide shows the same kind of thing, very different drugs for prostate cancer. Again, that vertical line reflects a payment change. It's actually tricky what happened there, but it was really clear to the doctors what happened. Lupron became much more, the blue line became much more profitable. Trelstar, the red line, became much less profitable on the day Q1 or the first quarter of 2010. And you can see what happened to utilization. So how we pay does matter. So in that backdrop, CMMI, it's a component of the Medicare program created by the Affordable Care Act, stands for the Centers for Medicare and Medicaid Innovation. They just proposed bundled payment or episode-based payment for oncology. They have just, if you will, a thumbnail sketch. CMMI has not finalized the model, but the paper they put out that went with this provides an anticipated payment structure for an episode. They said 6 months is an episode for a person with cancer. There's 3 parts of it. We'll keep paying the regular way, fee for service. Every service you deliver, you send a claim, we pay you. For A, which is hospital, B, which is doctor, and D, which is prescription drugs. And then an additional payment to the doctor per month per patient, which is intended to finance the care transformation. And then a performance-based payment. I'm going to talk a lot about this. That's based on the difference between expected cost and actual cost. In other words, if you save money against what you were expected to spend, Under the old system, you would lose money. Medicare is now going to go to you and say, thank you for saving money. Here's some of the savings back, essentially a bonus for spending less. And so that was not only the idea there, but it's been pretty well documented that those sorts of incentives do actually cause doctors to pay substantially more attention to what they're doing in terms of spending. That performance not only will depend on how much you spend, but also on quality. And you can see where the vectors or dimensions of quality that Medicare is proposing to look at they would characterize as higher quality or lower quality care. And it goes all the way from counting up things like visits and hospice days to patient surveys about how satisfied they were to the amount of face-to-face care they get. Some major organizations, ASCO and the Community Oncology Alliance, have related payment reform proposals out there. ASCO, shown on this slide, doesn't look that different. It has a new patient payment, a treatment month payment, a non-treatment month payment, which you either are treating a patient actively and get payment, or you're not and you get a different payment, which is less. A transition of treatment payment when the patient is discharged, and then continued fee-for-service. So not much quality in there, just payment more for longitudinal care without a payment for savings. And then the Community Oncology Payment Reform Proposal has 4 phases, moving from quality reporting in the upper left to quality and value performance to shared savings to an episode of care with shared savings. Shared savings being exactly what I described. When your practice spends less overall, they get some of the savings back from Medicare. And so you can see of the ASCO versus COA, or Community Oncology Alliance, payment reform proposals, what Medicare has put out looks a lot more like the COA proposal than it looks like the ASCO proposal. Back to episode-based payment, just to make this crystal clear, it's very easy to talk about these things in general terms, but if you think about, here's an example looking at drugs alone. If you went to an oncologist and you said, here's a payment of $3,500 just to cover the chemo and the administration of chemo for your patient with lung cancer, this is what it would look like based across the 8 different regimens that the NCCN recommends for a patient with lung cancer. Remember, I showed you on that slide how we pay matters. You can see exactly what would happen if you set the rate at $3,500, that dashed line. All 3 regimens to the left of it, which include Lilly's drug pemetrexed, for example, would cost more than $3,500 for the doctor to buy, but they would only be getting $3,500 to buy it. So they would be underwater, losing money. The contrast, the 5 regimens to the right would cost less than $3,500, so they would make money on the right. So this is viewed as a huge opportunity to direct doctors to using cheaper therapies that are recommended by the NCCN, but also a frightening one if it steers doctors away from things that are potentially beneficial. There are lots and lots of examples like this for lung cancer. Here's the NCCN guidelines for metastatic hormone refractory prostate cancer, another area where there's a lot of patients and there's a lot of money being spent. And you can see the broad range of therapies, different treatments that the NCCN says is appropriate. And I won't show you the prices on here. I don't think I have that slide. But if I did, they range in the price from a few dollars to tens of thousands of dollars. Doing these things will save money because it will steer doctors to lower-priced regimens. And if you come back to the CMMI slide and the notion of shared savings or spending less than expected, those expectations are dictated by how doctors spend money today. So over time, if we continue to monitor how doctors spend money, then our prediction of how much they'll spend in the next month or on the next patient will continue to fall as they get better and better at saving money. And as that happens, the expectation falls, the average payments fall, savings accrue, beneficiaries spend less on cancer care, we spend less on taxes. So this is all the idea behind these, making doctors and hospitals responsible for how much they spend and able to earn money by spending less. Those are all ideas that would, over the long term, reduce either the rate of growth in healthcare spending or just overall spending. Here's some examples of companies with pathways. Proventus has actually now been purchased, is shown on here, and so is P4 Healthcare, has been purchased by Cardinal. But these are all groups in the business of getting doctors to agree to follow lower price treatment pathways in exchange for higher payments from insurance companies. Most of the time, the data that we're seeing, at least from these, is that payer contracts, when they link the doctors to particular pathways, sort of like what I showed you for WellPoint from the Wall Street Journal, that the doctors are able to do whatever the pathway says, at least 80% or for every 4 out of 5 patients. Now, Medicare says they want to also index the payment to quality. This is a rapidly growing area, cancer quality. I play a role in one of the major organizations working on this. I chair the task force for Medicare to develop quality measures for cancer hospitals. But the standard bearer today for quality measures from the federal government's perspective is something called the National Quality Forum. They have a number of cancer measures in their portfolio. Today there are 60, and of these, and you should understand that quality measures can be thought of as belonging in general to one of 3 buckets. One is process. When you have a patient with A, you do B. One is structure. Your hospital has certain specialty care. Your emergency room has certain facilities. And the last is outcome. The patients you take care of are likely to live or die or not suffer or have good pain relief. Outcomes for the patients. Most people will say structure and process are important, but they lead to outcomes, and that's what we should be measuring. Of the 60 measures in NQF, we are still in the early days. 82% are process, only 8% are outcome measures. The committee I chair, the PCHQR measures, I won't tell you what that stands for because I no longer remember. But of those measures, we too have mostly looked at process measures, although we have a few outcome measures, such as how often patients in these hospitals get infections from either bloodstream lines or catheters. But most of these are process measures, important ones, such as if a patient has, under the age of 80, has lymph node positive or stage 3 colon cancer, that they at least considered or got adjuvant chemotherapy, which has been shown to increase survival substantially. The same with breast cancer and other sorts of things listed on this slide. There's also a patient engagement component. Now, I've been interested for some time on the crippling effects of rising cancer drug prices. They are rising to an extent that coinsurance, the piece that the patient has to pay, is causing severe financial problems for patients with cancer who are often on fixed incomes, who often if they're younger, lose their jobs or have to cut back on work or reduce their responsibilities because of their cancer diagnosis. And in the midst of that, insurance companies have structures in place to pass on substantial amounts of the cost, and those amounts are generally indexed as a percentage of the cost of drugs. So as drug prices go up, the total amount patients owe goes up. Scott Ramsey at the University of Washington recently showed that you could track bankruptcies in the state of Washington linked to cancer diagnosis, and that all other things being equal, if you got cancer, your risk of bankruptcy went up about 2.5 times. A number of people have also quantified the effect on people not going bankrupt, about $18,000 they would spend on their cancer care out of pocket. And there was a recent article I'm going to show you that this out-of-pocket expenses was leading patients to not take potentially life-saving medications. So really important, but we have been tracking the price of cancer drugs at the time they get introduced. We've tracked it all the way back to the beginning of the Medicare program in '65. This is a graph, needs to be updated with a few more drugs, of this rise. And here's a graph, a scale for those of you who are math geeks, on the log axis, on the y log axis, so you can see what is a 100-fold increase in the median price of cancer drugs since the beginning of the Medicare program. You could say that's inflation, but in fact these are inflation-adjusted numbers. So they're all, I believe, 2013 dollars. And it says that on the y-axis. So this is apples to apples comparison. A drug coming on the market at the beginning of the Medicare program in today's dollars cost around $100, and now it costs about $10,000. Those numbers in the U.S. are unique. In other parts of the world, not just in developing countries in Africa or India, but in the developed world like Western Europe, nobody pays the prices we pay in the U.S., even if they're buying exactly the same drug, manufactured in exactly the same facility. Here's a graphic from the New York Times that I really like. This is not cancer drugs, but I'm a pulmonary doctor, and so these are asthma drugs. For the same amount of money, you can buy one inhaler in the U.S., 7 in France. Here's an allergy drug. Now, if you go as far as Romania, a poorer country, you can buy 2 bottles of this drug in the U.S., 51 in Romania. And here's another drug, 51 in the United States, 9,100 of the pills, same pill in Saudi Arabia. This rising price issue is hitting patients, as I've already mentioned, but here you can see a table from Stacy Ducicina and her colleagues at Harvard. Stacy's now at UNC, showing that cost sharing, the amount patients have to pay out of pocket, affects whether or not they take tyrosine kinase inhibitors. TKIs are drugs like Gleevec, life-saving drugs that have turned around a disease that was previously fatal. And if I can just walk you through this, what this shows is the patients with a lower copayment, that's in gray, about 10% over the period of time, 6 months that they looked, stopped their medication. If they had a higher copayment in the top quartile, it was about 16%. And then a similar analysis performed around adherence and non-adherence, meaning not completely taking your drugs. Again, higher copayments equaled less taking of a life-saving medication. So, and to remind you, this cost sharing travels with the price of the drug. So if the drug is $1 and you owe 20% of that, it's 20 cents. If it's $10,000, you owe 2,000. So these things are, the base price of the drug is inextricably linked to the amount patients have to pay. The pharmaceutical industry has become fond of blaming insurance companies for this, and they certainly plenty of blame to go around. But at the end of the day, if the coinsurance is a percentage of the drug price, it will always go up if the drug price goes up. We have taken a stand against this, and this is something I am proud of, and it's an important, I hope at least it'll end up being a milestone in this discussion about drugs. This is a graph showing the rationale behind Sloan Kettering's rejection of the drug on the left, Zaltrap, because we already had a drug called Avastin, Genentech's drug, on the right for second-line metastatic colon cancer. And the reason we rejected Zaltrap was it cost twice as much as Avastin, and these 2 studies, they're not the same study, they're 2 related studies done in the same population, showed that Avastin was equally good as Zaltrap, and actually the side effect profile was slightly favorable. And because of that, we rejected it, and here are 3 headlines around that. We wrote a piece in October 2012 saying we're not going to use the drug because it costs more and affects our patients, and then less than a month later, the drug maker, Sanofi, reduced the price of the drug down to that of Avastin, and then we got a favorable editorial to go with it. But we're not the only ones. Here's the falling price of Zaltrap from the Medicare files. There's a similar, if you will, voice out there about these prices and drugs. This is from an article signed by 100 experts in CML, the drug that the disease that Gleevec targets, with the prices of 3 drugs, not just Gleevec, which is imatinib, but the other 2 in different countries, and essentially making the argument that you cannot have price differentials that are this large compared to other fully developed, economically thriving countries. And you can argue about some of the countries on this list as not being first world, but you can't argue about a country like Germany or the United Kingdom or Canada. They're seeing large discounts relative to what we are paying and what our patients are paying. Because this cost of drugs is such a pressing issue, ASCO has come out and said for the first time that they would like doctors to take price of drugs into consideration when making treatment decisions. They're calling it a value initiative. They're not saying price trumps. They're saying after you've considered efficacy or the benefits of a drug and toxicity or its side effects, then if all other things are equal, it's perfectly reasonable to consider price. That is, of course, what we did with Zaltrap. We said that we found that the drug was equal to Avastin or maybe even slightly worse, and then we rejected it based on price. This is what ASCO is going to develop under their initiative. It turns out that cancer isn't garnering the biggest headlines, at least for the next few weeks, because of the drug for hepatitis C, which Express Scripts, a major PBM, has now said that they are going to try and reject, although I don't think it's going to work out for them, because Gilead has launched a drug for hepatitis C that costs $1,000 a pill. You have to take 84 of the pills to be treated. The cure rate is somewhere between 70 and 80% probably for hepatitis C, but it's $84,000. And then in the cystic fibrosis marketplace, there's a similar drug called, I believe, Kalydeco, raised, nearly entirely developed under the auspices of a not-for-profit, the Cystic Fibrosis Foundation, using donations from patients and other concerned people, turned into a drug that ended up being so expensive that some of the patients on the study that led to its approval were unable to obtain it or had huge costs obtaining the drug that they took in the studies that led to the drug's approval. I continue to focus on this issue as one that is pressing and that we need to continue to ask questions about the rationalization and the justification for pricing. I want to walk you through a couple of things that I've been working on, one which I published, one which I hope to publish soon, around this issue. It gets directly to this question of personalized medicine and the general arguments that the industry has been using for pushing through higher prices. And this is all in the context of the fact that these drugs I'm about to talk to are pills, and that the coinsurance on some of these expensive drugs can be 20%, and in some cases 50% for patients. So we should be concerned about it. These are pills for lung cancer, a disease that in general affects poorer patients because smoking is primarily a behavior of the more disadvantaged. And put it another way, people who smoke tend to be poorer than the average. So we are talking now about a drug for a disease that tends to affect poor people, which has a very high cost. So we should be concerned about it. But this is the background. ALK is one of the genes or gene defects that has garnered a lot of attention because of its potential to have a drug created that would target the defect and seriously affect the future of the cancer in a positive way for the patient, interrupting the cascade of events that cause cancers to grow and spread. And in fact, this ALK defect was discovered only a few years ago, about 7 years ago. It is present in somewhere between 3 to 7% of patients with NSCLC is lung cancer. And I wrote a piece about this important mutation and what I don't understand about how things are priced relative to the arguments that the pharmaceutical industry gives for pricing them. And here is the slide that was the centerpiece of that article. It was essentially a thought experiment where I asked the question, here we have two real drugs, drug A and drug B. One approved in 2011, one approved just this year. And I basically asked the question, if the pharmaceutical company's arguments about the cost of research and development being high as the primary reason for how they price their drugs, then what conclusion would you draw from the following facts? And there's no disputing the facts that are on this slide. They come right off the labels for these two drugs. These are the facts. The two drugs have similar objective response rates. They work just about as well. They have similar durations of response, meaning the amount of time that a patient appears to benefit from taking it. If anything, drug A looks slightly better. They both have a reasonable side effect profile. Drug A has to be taken twice per day, drug B once per day. Neither one, remember I showed you all those different pathways for the FDA approval, both of these were approved under accelerated pathways which did not require a randomized controlled trial. Drug A required 2 different trials and 255 patients total. Drug B, only 1 trial, only 163 patients. Trials are the most expensive part of the development process, so drug A the people developing drug A spent more, had to do more trials, took longer. Then the question is, well, did they enter into a market where there was already somebody before them, where there was a first-in-class before them? And for drug A, the answer was no. They were new. They were targeting the ALK mutation and no other drug was out there. Doctors didn't know about it necessarily and they had to educate them. Drug B came 3 years later into this mature market that drug A had paved the way for. And ALK had to be looked for in lung cancer. And so the people developing drug A had to get a companion diagnostic, a test developed to look for the ALK mutation, developed by somebody else, not them, marketed, tested, and actually approved by the FDA on the same day as drug A was approved. A real victory for personalized medicine. For drug B, they didn't have to do it. It was already done for them by the makers of drug A. Now I should tell you that I don't have any relationship with the makers of either of these two drugs. I've been critical of both of these manufacturers at times in my life, but I would ask you, I guess you're all muted, but I think I can guess, based on the argument which should cost more, there isn't much question here. It should be drug A. They did more trials, they took more risk, and they developed a companion diagnostic. And that is not at all what's happening. These are the prices, these drugs, at approval, and I can tell you that their prices are similar to that today. So this, if you will, counters many of the arguments that have been advanced about the rationale for pricing drugs the way we have. Drug B should not be more expensive based on these arguments. It should, if anything, be cheaper. And the drugs, so you know, are Xalcoria from Pfizer and Zycadia from Novartis. And in fact, I'm under the impression at this point that the argument that we need these high prices to drive innovation is a little bit vapid. And the reason is twofold. One is, from a theoretical basis, why would pharmaceutical companies set their prices to fuel innovation but no higher, when they have no barriers to pricing them higher than that and generating more profits? And please don't misunderstand me. I don't expect them to do anything but behave in a profit-seeking way given the constraints of the marketplace. They're behaving as they should be, and they're behaving as if I were a shareholder, I would expect them to. I just don't like the rules on the rules of the road. But here's the argument. Remember that ALK, this mutation, is rare. 3 to 7% of patients with metastatic lung cancer. There's probably, give or take, about 70,000 patients a year with metastatic lung cancer. 3 to 7% of that, you can do the math yourself, is a few thousand people. So it's not a big market. The science only came out in 2007. If you had a market that was appropriately priced for innovation, once a few people got in there and innovated and created new compounds, other people would shy away because the profit potential would be reduced by the presence of competitors. It's a classic situation for a market. The alternative is that the market is extremely rich or fat or frothy, that there's huge profits to be made relative to the cost of trying to get into the marketplace. And we've seen that with many technologies, that when things are overpriced at first, people rush in and you have many competing products and you quickly descend down to a few that are successful. And we see those often with markets that are artificially supported for societal benefit, such as markets for alternative energy. So the question is, which one is it for ALK? And which one is it for cancer drugs in general? Is it an artificially supported market with too many entrants, or is it pretty well calibrated? And the evidence of pretty good calibration would be after entry into the market of Xalkori in 2011, and now entry in April of 2014 of Zycadia for what is a rare condition, we really shouldn't see other players trying to get into that space. But in fact, we see lots of them. After Xalkori was approved, you can see all the other people who got into the space, both before Zycadia was approved, and trust me, everybody knew about Zycadia's development for at least the last 2 years. And in fact, after Zycadia was approved, which is just a few months ago, we've had 2 more human trials started, and there are 4 more drugs that we know are already in preclinical development, meaning not in humans yet. So this is evidence of a very frothy, artificially supported market, not one that is well priced to fuel appropriate innovation. The last few topics I'm going to talk about are the care shift. You will hear a lot about this. There is no question. When I started at the Medicare program in 2005, when I was the senior advisor there, it was about 75% of all care of Medicare patients and the community and private patients tracked similarly were in the community, meaning mostly private practice doctors' offices owned by the doctors or owned by networks like US Oncology, in business for themselves, and about 1/4 to 20% to 25% were taking places in hospitals and hospital outpatient departments like where I work at Sloan Kettering, or at major academic centers, or other things with which you're familiar. And it held steady until about 2008. And then there's been this very large shift. And as of 2 years ago, we were at 63 and 37%. If we fast forward to today, we're probably approaching 60% or slightly less than 60%. So if you will, a decade, or in 2005, 4 out of 5 patients with cancer, or 3 out of 4 patients with cancer were in the community. Now we're close to 3 out of 5 are in the community, and 2 out of 5 are in hospitals. Why is this, and what's the problem, or is it a problem? And you will hear a lot about this issue being a problem. And there's a couple of things that are happening which are problematic, that are driving this, and I'll tell you sort of where I sit on this. The first is, plain and simple, the business model of outpatient oncology at the private practice level has collapsed. That business model was always anchored to very large profits from cancer drugs, 20, 30%. That's how those practices were financed. That's what drove huge profits. That's what drove expansion. And Medicare and then other private insurance companies have taken that away. They went from paying 20 to 30% in profit for every drug administered to paying 6%, and then with the sequester it went down to 4.2%, and then in Obama's budget for next year it's supposed to go to the 3%, which will never happen. But these things are changing the market from a very profitable one to one that's extremely tight. And then if I can say one more thing, which is a little more technical about this, as prices rise, the financing costs of the drugs also rise. And as profitability falls, the cost of that financing, the interest rate doctors have to pay to borrow the money to buy drugs, starts to rise because banks start to say, wait a second, it may not be that easy to pay it back. So they're getting margin squeeze or margin compression, and they're going out of business, particularly the smaller ones who don't have the negotiating leverage to get the drugs at a discount, and they don't have the negotiating leverage to get financing at attractive rates. So in a classic sense, they're just getting outpaced by bigger businesses with bigger balance sheets and more marketing leverage. It's sort of a classic behavior of a market. Whether or not it's good or bad, I'll get to in a second. There's another force that is perhaps more insidious, which is that an old provision, which used to just target poor clinics, called the 340B drug discount provision, has been wildly expanded by a series of laws, including the Affordable Care Act, to include many, many U.S. hospitals. And this law says that these hospitals get huge discounts on drugs. They have to. If the company wants to sell to these hospitals, Medicaid programs, they have to give them huge discounts if they're these hospitals for the poor, 340B hospitals. But they don't have to pass on those discounts to their patients or to the insurance companies who serve those patients. So hospitals can do the math and say, wait, I can get drugs at a huge discount, and then I can go find patients who are wealthy and well insured, and when I treat them, I'll give them the discounted drugs, but I'll get to charge your insurance companies and the patients through their co-insurance as if it were a retail drug. And that's exactly what's happened. So these hospitals, the numbers rising that get the discounts, have gone out and started purchasing these oncology practices, and when they do that, they pass through the discounted drugs for profit, and they've been purchasing them like crazy. There's a good part of that, and there's a bad part of it. I'll get to it in a second. But the projected consequences of these two moves are, as more care moves to hospitals, private insurance rates rise. Why? Because private insurance companies are less good at negotiating with huge hospitals that they need in their networks than they are with private practice docs, whom they don't necessarily need a particular practice to succeed as an insurance company. So hospitals are just much better at extracting higher rates than private practice docs are. You also get market power through consolidation, so it is a spiral where as hospitals get higher rates, they buy more practices, they shrink the number of available providers, they start to get monopoly power, and the insurers get further and further backed into the corner where they have to pay higher and higher rates because they need to have hospitals, they need to have cancer doctors in their portfolio of benefits in order to sell insurance in most places. This is a slide on 340B. I've covered most of it with words. This is the program I was talking about. It has made the press all over the place, the New York Times, congressional hearings. There's been a couple of examples of major clinics like this one in the New York Times, the West Clinic, selling their entire operation to a hospital that had 340B discounts. The doctors didn't go with it. They're now under contract with this hospital. But still, this is a major community provider collapsing into a hospital, and in return, discounted drugs flow through that community provider, but that provider sends bills to the insurance companies as if they're getting the drugs at full price. And here's Lear Schwartzberg, a major figure in oncology, saying, in fact, yes, the 340B program was a factor in the decision to form a partnership with Methodist Healthcare. This reinforces what I just said. Very few hospitals pass on the discount of the drug price to their patients or even their uninsured patients. Here's a graph showing the expansion of these. In 98, it was 8,000 hospitals. Now, in 2011, it's more than twice that, and it has risen since then. I like to be an optimist, or at least I like to accept that some things are happening and look for the opportunities they have created. And there's quite a bit of evidence that this shift has happened, and I've been digging around trying to figure out why this could possibly be good instead of bad. And there's some good, there is a possibility here. There's a lot of reasons why it's bad: excess market leverage, the collapse of community oncology, decreased access, extra cost to patients. But here's a slightly different way to think of it. Actually, you know what, I'm going to skip this one. Shown on this slide are exactly what I mentioned. These are different drugs for cancer, their uses, and the POV and HOP cost. Let me decode that. POV stands for the physician office, the private practice office. HOP stands for hospital outpatient, or the hospital. This is what insurance companies are paying private practice oncologists or hospitals for drugs when they give them the exact same drug to, theoretically, the exact same patient. This is the higher prices being pushed through I talked about. This is a bad part of the equation. But what could be good? Well, for one, in this trend towards consolidation and accountable care and integrated delivery, there's no question that hospitals are closer to being the cornerstones of integrated delivery than our doctors' offices. Hospitals can charge insurers more, but the flip side of it is they can get bigger drug discounts because they're larger purchasers. So they are more profitable as a result. But at least we should look at those drug discounts as something that could be potentially taken advantage of. Hospitals can more easily go to salary and staff model. And so, I'm sitting here in my office today. I'm a salaried physician. The amount I make is independent of the amount of patients I see, the number of procedures I perform. Most people will tell you in healthcare policy that salaried physicians tend to overutilize services less frequently than doctors who can profit from it. Put another way, if you take the incentives to do more away, the economic incentives, doctors tend to do less. That's probably a good thing. Most of the healthcare systems we look at today that we hold up as shining examples of high quality, efficient care follow a salary and staff model like Kaiser Permanente. And in this world where we circle back to my earlier slides, we want hospitals and doctors to start taking risk. And if they spend more, they suffer. If they spend less, they benefit. Hospitals are much better equipped to do those sorts of things. They have more money. They have larger balance sheets. And in fact, if you go back to this thing I've been railing against, the 340B, and you go to doctors' offices cannot qualify for this program, but if you go through the math and ask yourself the question, if we just changed one thing, if we just had the hospitals pass on the 340B discount to Medicare and to private insurance and to their patients, what would happen to the difference in prices in these different settings? And the truth is, all of a sudden the hospital would be cheaper. And these are 3 different regimens used to treat colon cancer, illustrating that. All we would have to do is ask the hospitals to pass on the discounts. Now, the hospitals will be reluctant to do that because it's profit to them today. But nevertheless, if we passed on these discounts, we could take advantage of the consolidation and its potential benefits, like more care integration, doctors on salary, more elaborate EMRs, and more sort of integrated networks. And then we could also probably get savings from it. Now let me pitch one other thing I wrote and tell you that I think that the advocacy world is atomized. A friend of mine always refers to it as like an Israeli parliament. There's 63 different parties or something like that in the Israeli parliament. Don't quote me on that because I'm not an expert. That is true in the advocacy world as well. Everyone has different views of a number of important issues. But you should know that just, I guess, last month I wrote about Amy Robach and her statements that I heard at Gilda's Club about her battle with breast cancer. And I'll show you a couple of excerpts from it. This is in the backdrop of my coming to this meeting to help fundraise for Gilda's Club, which is a local organization in New York that provides support primarily to patients with serious cancer, metastatic disease, or in many cases terminally ill. And Ms. Robach talked about, well, and a lot of things, so I'm just going to read this to you, 2 things that I thought were particularly problematic and we see throughout the cancer world. She went on to tell us about having her healthy breast removed along with the one that had cancer, labeling it, quote, the most aggressive treatment. She told People magazine that she went this route because she wanted to be around for graduations and grandchildren. But women at average risk of breast cancer, i.e. who lack the genetic defect that Angelina Jolie carries, increase the likelihood that they are alive in 20 years by less than 0.5% for the surgery Robach chose. No expert or guideline advocates Robach's choice as a standard for care. Many warn it is inappropriate. And I wrote this, and I'm going to show you one other thing I wrote, because Amy Robach is listened to by millions and millions of people every single morning. And she spreads information that's factually wrong. And this was sort of my alarm at that. And then I talked about what she said. Robach's core thesis also troubled me. I kicked cancer's butt, she told us. I wrote, hitting each syllable, pausing for applause. She recently buttoned an interview with the phrase, fight like a girl. Using the pugilistic fight metaphor is nothing new. The American Cancer Society has a sword in its logo, so I shouldn't have even blinked, but I winced. If Roback kicked cancer's butt, then what about the 40,000 women this year who will die of breast cancer just like my wife did? In Roback's lexicon, they must not be up to the fisticuffs, to taking the schoolyard bully outside and showing him a thing or two about standing up for oneself. They must be dying for their lack of fortitude. And I wrote this because I think we all have to decide how we're going to talk about this disease and whether or not we want people to anchor to metaphors which end up abandoning them when things don't go well, or if we want to have a franker discussion, even as we push to save people's lives and reduce risk of suffering and death from it. I don't think we need to sugarcoat things. I don't think we need to use heroic metaphors in order to make progress. And I think the risk of doing that, never mind Roback's arguing that some of the things she did saved her life when the data don't support that. But I think the risk that we talk about using warrior metaphors and victory metaphors ends up leaving behind the patients that we, at least who take care of patients with cancer, primarily do professionally. In other words, I'm in the business of taking care of people who are suffering of a disease, not of cheerleading, even though you can be encouraging. So that was why I wrote that piece, which got some attention. Anyway, thank you very much for your attention.
Thank you very much, Dr. Bach. I really appreciate that presentation. It was excellent. We were all taking a lot of notes here. So next we're going to go into the question and answer. And Eric, can you explain to people how they can ask a question?
Absolutely. If you would like to ask a question, simply type your question in the chat box area located on the lower left corner of your screen. Once you have entered your question, click on the Send button located next to the box. Your questions will not be viewable by other attendees. You can also ask a question through the phone if you are dialed in. To ask a question, simply select *1 on your telephone keypad now. Please note that *1 will not work if you are using a speakerphone. Please pick up the handset before selecting *1. If you are waiting to ask a question and decide you no longer wish to ask that question, select *2 to remove yourself from the phone queue. Shelley, we're ready for our first question when you are.
Okay, great. The first question we received via text is, what are the patient's perceptions of quality of care when their doctor is adhering to pathways? Is there any difference from standard of care?
I appreciate the question, and I think the reality today is, and I have been raising this objection for some period of time, most pathways companies, including the ones I showed on the slide, keep those pathways and the contracts around them, meaning when doctors sign and say, I will follow this pathway 80% of the time to get payment from my insurer, they keep those things confidential, citing proprietary or competitive information. So they will tell you when asked that all the pathways adhere to evidence-based recommendations, but it is impossible to verify that because they won't make the actual pathways they've agreed to follow available for review by independent organizations or anyone like that. I also do not believe, I've only asked this anecdotally of doctors who've agreed to follow these pathways companies or pathway agreements, I do not believe patients know that their doctors have financial incentives to choose a treatment that's contracted around over a treatment that may be the doctor's preference if they were not hindered. Please don't misunderstand that. I'm not saying that that's a frequent or a rare scenario that the doctor would prefer a different regimen. I have no data on that, but I don't think patients know about that. The WellPoint project that I pointed out that was in the Wall Street Journal is an exception to this. The pathways are posted on the AIM, their vendor's website. So you can actually see those, but I still don't know if patients walk in and know their doctors are going to get $350 if they follow on the pathways that WellPoint's posted.
Dr. Bach, this is my follow-on question to that. I think you're right that patients don't necessarily know that doctors have an incentive to stay on pathway, but I would also say I don't think doctors know that patients know that doctors are paid on a chemotherapy margin either, which to me as a patient advocate is just as disconcerting as any payments they might be getting to stay on pathway. How would you comment on that?
Yeah, I hate to try and rank things that I consider to be noxious. I just would put them both in the general category of highly undesirable for the optimization of patient care. And I think you're right that patients don't understand the economic models. I mean, the truth is patients have no idea, and neither do doctors, what they're about to pay for something they're about to receive. At the pharmacy at least you get the bill, I guess, after they hand you your prescription bottle, but when doctors prescribe treatments or tests for patients, it is the rarest of exceptions, unless they're in a capitated closed plan, that even the doctor would know what the patient's about to pay, never mind the patient.
So another question that was submitted by one of our audience members is, how do you think drug prices should be set, and to what extent should government be involved in establishing drug prices?
So they're two different questions. I think at a minimum, we should start anchoring prices in some way to their clinical value. I don't pretend to have all the answers, but I think what's probably generally accepted is what the components of that value might be, and I think all of the arguments would be about how to weight the different components. But I think most people would agree that how big the benefit is and how bad or good the toxicity profile is would be important components of price. And I think most people would agree that drugs that treat smaller populations probably should garner higher prices so that revenue is sort of more similar than it would be otherwise. And then I think there would be honest disagreements about how much you should pay for something that is innovative versus that looks a lot like its competitor. I think my general view is test tube level innovations are important for science, but I really worry about what happens to patients when they get therapies. And at some level, I think it's substantially less important how we get to those endpoints, as long as we focus on them.
Okay, thank you. Do we have a call from the phone line? Is there a caller in the queue?
We do have a couple of phone questions, and we'll take our first question. And caller, please go ahead.
Hi, my name is Laura, and I'm curious about, I'm grateful for Dr. Bach's comments very much so, but I wondered if he could specifically talk about the plight of the underserved and the unique challenges they have, and I appreciate, again, his discussion of 340B hospitals not passing on discounts to patients, but I wonder if he's able to influence large institutions like MSK to change that, and if they are passing on discounts when and if possible, and what his thoughts are on the decisions of leading institutions to expand into wealthy neighborhoods rather than for communities where distance to treatment has an impact on the treatment that is actually accessible or not.
Well, I really appreciate your questions. They're covering a number of different areas. I think, let me answer the easiest one first, which is that first of all, I don't speak for Sloan Kettering. Second of all, Sloan Kettering is not a 340B institution. But I do take your point that there is a constant tension between margin and the amount of savings that are passed on to patients and insurers. And I think there's a long history of hospitals protected by tax-exempt status finding ways to milk their margins, and 340B hospitals are just one version of that. And I don't think my institution or other non-340B hospitals are exempt from that criticism in some situations. I do know what the response is from the hospitals in general, which is that they are failing even as they are building buildings. But I think that 340B is a unique situation because it is also causing this market collapse. And I think the expansion by 340B into wealthier communities, which is appreciated now and I think about to be well documented, is completely understandable economic behavior and completely antithetical to the mission and justification of the law, which was to improve the provision of care to poor patients. So it's, I see it again as a natural behavior given the rules of the road, but a problem for the rules of the road themselves. Now, in terms of underserved patients, I don't really know where to begin. I try as hard as I can when I look at situations in oncology or in the care delivery system to ask what policies could either be targeted or always thought around the optimization of care for those most in need. And the underserved have a terrible correlation of factors that worsen their outcomes in oncology. Everything from lower levels of educational attainment on average, which tends to affect compliance, adherence, and comprehension, to less access to ancillary care, less social support, higher degrees of risk factors and comorbid disease that makes treatment harder, and this is also well documented at this point, generally poor access to the high echelons of the healthcare system. The hospital down the street in a poor neighborhood is less likely to be high quality than it is for a wealthy person. And that's not my opinion, that's what research shows.
Thank you. Can we take the next caller in queue?
Yes, we'll take our next question. Again, caller, please go ahead.
Is this me?
Yes.
Hello. Yes, this is Iris. I asked this question from the perspective of being a 15-year breast cancer survivor, as well as a patient advocate. Two parts to the question. The first is just procedural. Your data is really fascinating. It addresses a lot of questions to myself that I had over time and have had in recent years on this. I myself went through almost a year of different chemotherapy treatments, some of which were experimental, and I did wonder about the treatments, but I was not paying different amounts myself because of the health care plan I was on at that time, which was really fabulous. So this is really great information. Will your data be accessible to us, your PowerPoints, online after this talk is done? Will we be able to reread the information that you've given us?
I think
this is not my basic question, but...
Okay, well, I think the quick answer is a partial yes, and I think I'm going to work with NCCS around this, and I would say the vast majority of it will be. Okay?
Great. Now, this makes a lot of sense, that question, because I'm asking you a question about one of your earlier charts, one of the very first charts that you used, which I'm not looking at the moment, so I'm just remembering it. It was an early chart that tracked very vividly the correlation between price changes or reimbursement changes for a drug. I believe it was lung cancer drug, and how frequently it was prescribed, with a fairly precipitous drop on the second half of the right hand of the graph. And my question to you about that, when I looked at it, was how did you factor in or screen out other factors that may have influenced doctors' choices about whether to keep prescribing that particular drug. I mean, for example, there are lots of factors that can come in over time. You can get new information about patient outcomes as patients are tracked over time in terms of long-term survivability and complications. There are studies that re-examine earlier data and see different results, and obviously, which is a very interesting issue right now, new data about long-term side effects or after effects of a drug over time. So how did you screen out?
Okay, so a couple distinctions. First of all, it's not my work. It's Murray Jacobson and Joe Newhouse's work from UCLA and Harvard.
Okay.
But this was actually economists would call this a sort of natural experiment. The data are cross-sectional. They're not longitudinal, which means that each sample, each month, is whoever's being treated for lung cancer that month in the Medicare program. So it's not patients over time dropping off necessarily, although there may be some of that. It may also be new starts. Nothing happened on January 1st, 2005 except a payment change in Medicare. There wasn't any other event. There may have been events within particular patients, but those should be evenly spread across all the months before January 1st and also all the months after. So,
and we know that because
there was an Go ahead.
We know that the researchers looked for that and found no other factors.
No, you don't actually. You don't need to because I mean, you could. I happen to be focused on lung disease, and I can tell you that nothing happened that day. But remember, on the next slide I showed you was for prostate cancer treatments. It was a different date. But again, all that happened that day was Medicare changed its reimbursement rules, and you saw what happened to the two drugs. So, yeah, it's actually, from a research perspective, a fairly elegant analysis, which can't be confounded.
Well, again, thank you for pulling all this together. It's very helpful. And that's it.
Great. Thank you very much. I have a couple of questions from the chat. One question is, if the drug costs in the rest of the world are much less than the U.S., why not introduce legislation to prevent this or add an export tax? And then a related question, I'm just going to give you both of these because they're both about the prices in the U.S. versus other countries. And are the countries where there is lower costs, do they have socialized healthcare as compared to the U.S. healthcare model?
All right, so two related questions of drug costs. In terms of the export or price-fixing legislation, there's nothing fundamentally wrong with either of those ideas. We tend to not go the way of the rest of the world. I think it was Winston Churchill who said, the United States always gets it right, but not before exhausting all of its other options. So we won't see, or I wouldn't prognosticate that we will see a price fixing or price anchoring kind of legislation to European prices, nor will we institute a meaningful export tax, because what happens is people move these businesses overseas, and many of these companies actually are overseas. Novartis is a Swiss company, I believe. Roche is a European company. Sanofi, the maker of Zaltrap, is a French company. So I don't think, it's not as if it's coming from the U.S., it's just they're able to sell it in the U.S. for much more money. And I think my prediction would be if we did set prices in the U.S. to European prices, the biggest effect of that would be prices rising in Europe, not prices falling here. The other question had to do with socialized medicine. It's not a term from a policy. I understand the term as a sort of a cocktail party chat kind of term, meaning run by the government. But in general, it's not. It doesn't help really delineate between the different countries and why they're achieving these lower prices. Medicare is a program run by the government. It's the largest health insurer in the world, much larger than the French healthcare system. So we probably have, in fact, the U.S. health economy is larger than France's entire economy, if I remember correctly. So we already have the largest government-run health program in the world, and so we are probably more socialized in that respect than many of these countries that are getting cheaper prices. A lot of people will argue that the distinction is that these countries will do something we will not do, which is that they will negotiate for prices and they are willing to walk away. You can't negotiate if you won't walk away. Medicare has specific provisions that require it to pay for every cancer drug. Once those provisions are in place, Medicare, even if we said, hey, Medicare, go negotiate, you can't really negotiate if you have to buy. It would be, imagine going to buy a car and knowing you had to buy that car in front of you and having the salesman know that you had to buy it. There's absolutely, you could say, well, could you give me $100 off? And the salesman says, no, and you still have to buy the car or the house or whatever. And so that's the current situation. And these countries, France, Germany, the UK, Italy, these are all countries that have rejected drugs that have been approved by the FDA, rejected drugs that have been approved by the FDA equivalent in Europe, the EMEA. And they said, you know, it's not efficacious enough given its cost. We're not going to give it to people, and then people in Italy don't get it unless they're wealthy enough to buy a separate insurance policy. And their society is somehow accepting of that, or they at least haven't voted out of the office the people who've done it.
Okay, here's another question from one of the participants who commented that she was a bit surprised not to hear health IT among the priorities covered. Can you give your take on where you think this fits in with regards to opportunities for cancer care?
No, well, thank you for your question. It's ironic since I was a member of President Obama's Health IT panel, and I'm on the World Economic Forum on digital health, and I work on the IBM Watson project at Sloan Kettering around health IT. But maybe it's emblematic of a more general sense. I tried, when I was laying this out, I really tried to choose things that I thought were cancer specific and had particular nuance in cancer that wasn't generalizable across other areas of healthcare. And I think of health IT as certainly promising, important, maybe even revolutionary, but I don't see a lot of sort of cancer-specific things that look different to me than they look in care in general. But I can tell you, important, the meaningful use standards don't particularly speak, which are the federal regs for it, don't particularly speak to cancer the way they should, in my personal opinion. And if you wanted to advocate for something in health IT, a couple of things that we would like to see from a standards perspective is more basic documentation requirements around the most crude information of cancer, such as stage of disease. And also, because I work in the lung space, it would be nice if the meaningful use standards had more rigorous definitions around smoking history and status, because we use it to risk stratify patients. But those are narrow issues in health IT, in my mind at least.
Okay, thank you. Here's another question. Is the NCI approving and paying for too many clinical trials that yield marginal benefit?
I don't have an opinion on that one. I wish cancer progress were faster. I think the amount of money we spend on cancer research disappears in a nanosecond compared to the amount of money spent marketing tobacco to teens. So it would be very hard for me to look at anything we spend in cancer research and see it as squandering funds. The problem is we need substantially more money devoted to important research. Of course, not all clinical trials work out. I do think, in the narrow world I live in, one of my largest frustrations are failed trials, not trials that end up not being positive. That's the purpose of doing research, is to get answers. The trials that fail to enroll, fail to complete, fail to publish, don't advance knowledge. And we are running probably about 40% of trials funded by the NCI that no result is ever published from them. And that is unconscionable that human subjects are involved, and it's obviously a very poor use of taxpayer dollars to fund research that disappears into the ether.
Are there any questions on the phone, in the phone queue?
No other questions here on the phone at this time.
Okay, I still have a couple more here, but I wanted to make sure that we gave a chance for people calling in. So Dr. Bach, how will patients feel when they read about a newer drug that may be more costly for their diagnosis and their physician is using a much older treatment regimen? Patients come to offices armed with information from the internet, etc.
Yeah, I think it's a communication challenge at a minimum for doctors, and I think that there's a couple of countervailing forces here. One is if there's a legitimate argument that the older treatment or the less expensive treatment is equally efficacious and has a similar side effect profile, I think it's a communication challenge with patients, but it's one that's worth taking on. And obviously, when we wrote the piece in the New York Times and said we're going to use this older drug, Avastin, and we're not going to use this newer drug, Zaltrap, we framed that as a difficult decision for the public, but a no-brainer from all other perspectives, because new is sort of irretrievably equated with better. But I don't see that as a problem that we can't solve. We just have to message around it. But there is this problem that healthcare is highly competitive, and healthcare providers and hospitals, and fueled by innovators, tend to market themselves as offering the newest next thing. And that becomes a draw for patients, and patients are a source of revenue generation. In fact, the only source of revenue generation for most providers. So that clash is one that we also have to deal with, and I don't know how to deal with it. It would be nice if we had sort of a really rigorous standards for what people could claim and what they could advertise around, but that we're a long way from having that. And the best example, and this isn't oncology specific, but it's pretty important in oncology, is the robot. And hospitals advertise left and right that they have the robot, and every study I've ever seen, and a couple that we just came out with, suggests that the robot used for many of these cancer surgeries costs more and is no better, and in fact maybe has worse outcomes in some cases.
Okay, thank you. Here's another question. It would seem patient-reported outcomes are critical to understanding the ultimate value of cancer care. Do you agree? And if so, how can we go about collecting these data on a national scale? And how can we best have these data used by both patients and providers in end-of-life care decisions?
Oh, those are great questions. The first thing is I would say we don't need national, we just need what I'd call at scale. Patient-reported outcomes, at least for the purpose of fueling further research questions, for assessing the value and outcomes of care, for becoming the underpinnings of informed decision-making for future patients. We don't need information from every patient, we just need information from enough patients to be robust and a reasonable cross-section of patients. On the end-of-life care front, I think that I would wrap that in with all other decisions we ask our patients to make. If you think about the old paradigm being sort of driven by physicians and physicians' estimation of experiences of patients, being supplanted by one driven by patients and their own experiences and their narratives and their quantifiable information going back to future patients, I don't see much of a distinction between patients reporting on their satisfaction with different breast implant procedures following mastectomy or their experience taking third-line chemotherapy. There's obviously mechanical differences in terms of capturing that information, but at the end of the day, if we are going to have a paradigm shift, which I personally favor, towards the voice of the patient guiding future patients, of course wrapped in science and correct data, then we should be aiming to gather it from across the spectrum.
Okay, thank you. Another question, that when talking with people in the pharmaceutical business about the high prices, they always comment that research and development budgets would be cut if prices were decreased. What is your response to that?
Okay. I don't believe, I mean, that is essentially an argument that I was trying to take on with that chart about the ALK, number of drugs in development for ALK. If you follow that argument through, the pharmaceutical industry is basically saying we are calibrating our prices appropriately to maintain adequate investment in research to maximize societal welfare. And I guess, as I said before, under that hypothetical scenario, why would we trust, and this is not a blame thing, but why would we expect pharmaceutical companies to do that? They may claim they're doing it, but why would they do it as profit-seeking entities? Why would they stop there if we let them charge whatever they want? Won't they just charge whatever they think they can get away with, which is what all of our data suggests, is that that's what they're doing. So they will tell you that. There may be something to it, but it's really a question of what's optimal for society, and that's some balance between investment in research and development and use of dollars for other purposes. If we are bankrupting patients with cancer, that is a very high price to pay for a research and development program at a pharmaceutical company. And maybe it's worth paying, but we certainly don't want to overpay for it. And the reason I showed you those ALK data is no market for a rare condition that's already saturated by 2 efficacious agents should have 12 new entrants, unless it's extremely frothy. And as I point out, government subsidized programs such as those in alternative energy look just like that, right? Cleanup programs after natural disasters funded by the governments in a rush to get people back in their homes look just like that. They're overpaying, they're mismanaged, there's graft, corruption, things like that. And all of a sudden you have 100, you have 1,000 entrants into the marketplace because it's frothy. We know more than that about the cost of drug development, and we know substantially more than that about what markets should look like if they're appropriately calibrated. And this is a market that looks like it is really, really overpaying for people to enter it. And I said it before, I have nothing against this industry. I think this industry has brought more to improve human health probably than any other sector in healthcare. I think they are behaving based on the rules of the road they have been given, and unfortunately those rules of the road, if you will, have no speed limit on them, and now we're seeing meaningful negative consequences for our patients. And it doesn't matter if we have 4 more TKIs for CML if patients stop taking them because they cost too much.
Thank you. I have a question about the site of care. I appreciated your discussion about the shift in site of care. And I'm wondering, first of all, there's a lot of discussion about different ways of, different policy solutions or at least steps to take to try to change that trend. I'm wondering, is it too late to even stop that trend in shifting the site of care? And as patient advocates, I think we have to look at the patient impact, and we hear a lot of arguments about why, the negative impact on patients of shifting away from community practices, that potentially they may have to travel further, or that practices may be closing. I don't know if those are true, but we hear that. We do hear that the out-of-pocket costs are higher for patients. You gave some good arguments about why care in the hospital setting may be better for patients. But, where would you advise patient advocates to get involved or not get involved in this discussion? Because to me it seems like a little bit of a fight between the hospitals and the community docs, and I don't know that there's an appropriate place for us as patient advocates to be involved.
Yeah, I think it's tricky. I can, there obviously, and you already touched on them, there's a couple of things that I think are traditional advocacy issues that I worry about as I'm a sort of, I guess, de facto advocate at this point. One is access, but I would discourage people from assuming that local availability is the same as access, because, you may be better traveling a little bit to a highly integrated delivery system than you are being able to travel a little bit less to a local doc, so that one's going to cut both ways. But I do think that, and as I said, this is a technical issue. Consolidation of of markets for oncology care into hospitals and just smaller providers meaningfully drives up cost, and that affects access. So I think that's an important one. And, there is sort of this question, if you landed in a spaceship from Mars and you looked at what happens and you realize that if I were a patient today, and everybody's seen the data on this, and I'm in New York City, if I could get 9 MRIs, there would be a 5-fold difference in the cost of that MRI. It would be the exact same MRI. And if you landed in a spaceship, you would ask, why is it that the same service costs differently? And then if you walk into my clinic and I'm seeing patients, you'd realize that I can provide the same service for 5 sequential patients and get paid, or my hospital gets paid differently if they have 5 different insurance plans. And that's a real, to say the least, a head scratcher in the context of something that we all think costs too much.
Well, thank you very much. I could ask you more questions, but I want to be mindful of the time, and it is 4:30, and we really appreciate your time and all of the participants. We had a really great turnout and some excellent questions submitted by the participants, and most people hung on till the very end. So we are very grateful to you, Dr. Bach, for your thoughtful presentation of these issues and helping to explain these issues to us and address our questions.
Well, I appreciate you not saying the bitter end, and I really appreciate the attention and the opportunity, and I'm always happy to talk about these issues and flattered by it. So thank you very much, and thank you to all of you out there who listened.
And Eric, do you want to give us some closing instructions?
Yes, thank you. And with that, we will conclude today's webcast. If you take a look at the links box on the left-hand side of the screen, you will see the webcast evaluation. Please take a moment now to complete the evaluation and give us your feedback on this program. Then click on Submit when you have completed the evaluation to send us your responses. Your comments and suggestions are very important to us, and they help us to provide you with this kind of quality programming. Thank you for your participation in today's webcast. Today's program is copyright 2014 by the National Coalition for Cancer Survivorship with all rights reserved. This concludes today's program. Thank you.